I'm glad that we have uh, we have these opportunities. And so we've been what I'll share with you is some of our journeys that started back in 2012, 2013 when we started developing this idea. And these are my disclosures. Um, so we were interested in shared decision making and how can we inform patients. And then as we got down this path, the next step or the next grant we got was to, once we have effective shared decision-making tool, how do we make it effective in practice? How can we implement it? How can we make it available? So our project is implementation of decision aid for lupus in practice setting, which is the implementation project. It was preceded by the trial that tested that tool. Before testing it, developed that tool, and there's a lot of steps to the development process as well. But again, due to the short time we have, I'll try to keep this very focused on two major steps we completed. So why lupus? Well, it wouldn't surprise you that when we started, the tool I wanted to develop was rheumatoid arthritis decision aid tool, because I had led the 2012 RA guideline, and this was 2012. So when Picori was born in 2011, 2012, we said, let's go to them and let's just see if we can convince them to fund us to develop a decision aid for people with rheumatoid arthritis. So we got our patients together. We got 3 patients on our panel. We got Arthritis Foundation at that time, and we got a lot of clinicians together. Guess what? Patient said, Jazz, I don't think we need a decision aid for rheumatoid arthritis. I think where you need to go is lupus. I said, oh boy, the disease I've been running away from since my fellowship that I was told to stay out of, because there's so many giants in lupus, and it's complicated and it's complex. And I enjoyed that as a disease to treat my patients, but research-wise, I had just, having trained in one of the institutions that provided a lot of care to underprivileged people with lupus, and again, these are the reasons why lupus matters, is because of the huge amount of health disparities in lupus. Anyway, we got pushed into this because obviously the patients told us and the advocacy organization leader told us, we'll be doing lupus. And I said, but we don't have lupus guideline as yet. They said, it doesn't matter, Jazz. I think that's what we should do. That's what the need is. So anyway, we listened and changed the course and developed then a grant proposal to address this humongous disparities issue that exists, where lupus being 0.1% of the U.S. population accounts for 2% of the end-stage renal disease. It's got a 24 to 204 effect, depending on whether you take its prevalence at 0.1 or 0.01%. But even at 0.1%, it's 24. And the issue is that minorities, racial ethnic minorities, as well as socioeconomically deprived people, tend to develop lupus both more severe early on and die from it. In fact, the CDC study done by Sam Lim et al. Shows that 50% of young women who are going to die as a minority have already died before white young women with lupus start dying. So they start dying about 4 or 5 years prior to white women start dying because of lupus. So there's a humongous mortality gap in lupus mortality in young women in this country. So they end up in dialysis. The other issue that we were delving into is a totally new area, which is decisional dilemma for these drugs that are viewed as cancer drugs. These were discovered as cancer drugs. They're approved for treatment of lupus kidney disease because they save kidneys, they prevent dialysis, they prevent death. However, patients read about them and think about them and hear about them as cancer drugs. Again, these are not. These are the doses they use in cancer. However, that's what they perceive. And then there's a humongous issue with the fact that most educational materials in the US are above 6th grade reading material, and they assume numeracy skills in our patients, which don't exist in every patient. In fact, 40% of Hispanic patients and a quarter of African American, as opposed to only 9% of those whites have below basic health literacy. So we have a challenge where we need to develop materials that match the numeracy, literacy, and graphical literacy skill of the population that are affected by lupus, which is primarily minority women, low socioeconomic status. So what I've shared with you is that lupus is a devastating disease. And what I'm going to share with you in the next 2 slides is that we developed a lupus decision aid that is directed at the patient, that is both effective for the patients with lupus disease and is acceptable. And the evidence that's sort of provided below is the systematic reviews and the patient work we did to develop the decision aid. And so this is our original study, or the trial, that we call as the Individual Decision Aid for Diverse Women with Lupus Nephritis, or IDEA-1, which was a randomized trial. So what we did here was that we took, this was basically to address the issue of treatment decision-making in lupus patients, and we assessed the effectiveness of a decision aid that we developed to inform patients about immunosuppressive drugs and immunosuppressive medication decision-making. And we used standardized outcomes in this randomized trial, which is decision conflict, the low literacy decision conflict, which measures, how much conflict do you have in a decision-making after you looked at the materials. And also informed choice, which means if your values are against the immunosuppressive medication, you should not choose immunosuppressive medication. If your values are for, then you should choose. You should not have a mismatch. So informed choice is basically concordance of a decision with values. You can be totally against, and that's perfectly fine, but you should not then say, give me immunosuppressive drugs. You should say, I will choose not immunosuppressive drug, and other treatment or no treatment. So we looked at two those outcomes, and this was a 4-center trial in the US. It is open label, meaning that, we randomize people, but everybody knows what they get. They either get the computerized iPad administered decision aid that we developed, or the ACR lupus pamphlet that was the existing state-of-the-art 2-page material available in English or Spanish. And therefore, we developed our decision aid both in English and Spanish, and our materials were all translated into English and Spanish for both surveys, consents, and everything, including the decision aid itself. Adult women were randomized, those who had lupus kidney disease. We were really focused on getting the target population. We didn't want to just do an easy trial of just, what could lead to 60-70% white patients, and that's most of our studies tend to recruit elderly white women because they're very friendly to research, and they volunteer quite often. Our focus was something else. We wanted lower socioeconomic status with ethnic minority patients. People were, after they consented, they were either assigned by a computer at random to 1-to-1 ratio to the 2 interventions, which is the individualized culturally tailored computerized decision aid or the ACR lupus pamphlet. And here are the results of the study. So after 301 patients, they were equally randomized, 147 to the pamphlet, 151 to the decision aid. And here's a breakdown, which is probably the biggest achievement of the study. We have an 85% non-white population, right? It was not easy to recruit in the study. We had to have minority population research associate. It was very hard to convince patients. It took a lot of effort. However, we succeeded in doing this. And again, we have a very good mix of lower socioeconomic status. About a third had high school education or less. And the table below shows you the main outcomes, which is the decision aid and pamphlet out there, and the change in the decision conflict scale total score. The more you can reduce the conflict, the better off we are. So this reduced by 22 points here versus 12 points. The informed choice was seen in again, this is the unresolved decision conflict, which is a score above 25. It is present in about 20% of decision aid people and 44% of pamphlet people. And this is the informed choice, both by the original analysis that just sums it up, or by the predominant values against or and for in sensitivity analysis. And in one of the two of those, it is significant. So we found also that significantly more patients in the decision aid group, rather than pamphlet, understood the risk factors, medication option, and they liked the materials. However, the trial was limited that we didn't have men. This was a trial in women only. We had a short follow-up, and we didn't have clinical outcomes because the focus was the decision-making and informed choice. So this iPad-administered, computerized, self-administered patient decision aid was then, during the COVID period, transformed into and also made available as apps, and these are the QR codes, so anybody can download them. Depending on whether your phone language is set to Spanish or English, you will see it in either of the two languages. If you want to see Spanish, you'll have to reset your language to Spanish, and you can see it. And those are the QR codes. So you can save them, download, disseminate them. This is available worldwide, free of cost. There is no app fee to these two apps. So this shows you, and many of you may have already tried. I mean, this is, we try to keep it at the literacy and the numeracy level of below 5th grade education level, which means that you need to have words that patients understand, need to have words that patients want to find, and need to have pictures that can be easily understood rather than graph and lines that people don't. And so these were carefully chosen based on prior experience of our experts who helped us develop this. And this is a simple example of comparing two drugs. This is in the middle of the presentation, but every benefit is presented like this. And you have a link, hyperlink to what kidney function is, because kidney function is intuitive to physicians and to people who have graduate degrees and postgraduate diplomas and PhDs, as many of you have. But to somebody who's not even a high school graduate, they don't understand what kidney function means. And so they could always just click on a link, hyperlink, and go to more information on any and all of these terms. We have slides, many of them, that are exactly like that. We need to have pictures and we need to have few words. Here's another slide that shows you steroid-induced side effect of weakened bones for this. And again, like I said, for each of these pages, we always had a solution or more explanation page at the back, which are optional for patients. If they already knew about it, they don't have to click. So there's the option. This is what makes it individualized. And again, for everything, we provided them solution. The next step is our implementation study, which is what we've spent the last 5 years doing. And sorry for this busy graphic, but it shows you that in a short time frame of 36 months, which actually got extended to 4 years because of COVID, and then because we got a supplement, got extended to 5 years. So this 3-year study became a 5-year study where we did formative evaluation in the beginning, but we also did implementation using standardized capacity-based building activities, but also site-chosen, tailored activities, either focused on the patients or focused on the clinic. We measured outcomes at the clinic members level about how they perceive the acceptability and sustainability of this at patient level. And we did a time study as well. We did audio recordings, and we also did qualitative debriefing and using detailed qualitative methods. So let me just share with you 2 or 3 things from this implementation exercise or project. And this slide shows you the implementation of this patient decision aid in diverse population with systemic lupus erythematosus, or lupus, in 15 U.S. rheumatology clinics. And we basically just asked the providers to select any lupus patient coming into their clinic, or just in a lupus clinic, just make it available to all lupus patients. and try to measure the outcomes at baseline 12 and 24 months for the clinic personnel and baseline 6 and 12 months for the patients, lining them up at the time of their regular follow-ups. This is not a study where people are brought in to do research. This is implementation trial, and therefore we do assessments when patients come in for regular visits. And we assess a lot of clinic personnel associated organizational measures, as well as some of the patient measures we're involved in, like the shared decision-making, decision conflict, and satisfaction. We try to keep the burden of patient assessments low here, so we're not assessing numeracy and all the other things we would have loved to measure, but it becomes burdensome on patients. So we try to limit our questionnaires to patients at approximately 12, 13 minutes or less. So when we look at how well we are able to reach patients at each site, we take denominator as every lupus patient in that practice, because in our view, this should be available to every patient. However, we know making something available to every patient on top of their visit in a busy clinic where everybody has lots of things and a lot of new things added every 2 months by the administration and by insurance companies to document, it's not possible to add any task, even if it means a few more minutes in the room, even the coordinator is doing it. So our penetration varied from 3% at some sites to 44%. That's a more successful site, which was our own site in Birmingham. And then this right here in about 184 clinic personnel surveys shows you that with a higher score being more desirable for psychological safety measures, that we have a range, I think, for these scores, with the top score being 7 for various sites towards a higher but not highest scores. And also we have numbers here for the permanence and the success of the decision aid, which was quite reasonable and high scores. We're also showing you that the decision conflict on a scale from 0 to 100 is low. The matched role in treatment decision-making for patients is high, and that the patient-physician communication process score, which ranges from 0 to 18 to 90, was pretty high, and then the patient was still satisfied with the ease of use. We also looked at whether this decision aid is as effective when provided to patient in the clinic versus just sent as a link to patient at home during COVID times and post-COVID times. So we provided this link as the pandemic evolved in both ways, because we had to do that. And we tried to assess whether it made any difference. We looked at the modality and the device and the setting. The setting, or how patients viewed this decision aid, had no effect on the shared decision-making or patient outcomes, with very minor exception. However, when the patient got interrupted while viewing the decision aid, it was associated with significantly lower feasibility, acceptability, and shared decision-making scores. And if they were not able to view it completely, again, it was associated with worse patient decision-making and decision conflict scores. So what this showed us is that how and where patient sees does not matter. Whether they can look at it completely and whether they get interrupted really does matter. So very, very interesting findings, and speak to the universal disseminability of the decision aid in most settings. And the last thing I'll share with you is the patient perspective. So we did also a mixed method study to look for how patients perceive this. In addition to the shared decision-making and acceptability surveys, we also looked at whether they rated the information as just right, whether they had enough information, and whether they would have found this to be helpful. You can see scores ranging from 79% to 90% of patients saying yeah on that. Acceptability is pretty high, between 78 and 92% on various aspects of acceptability. And then we had a qualitative survey where patients provided a lot of valuable feedback. And the top three reasons for what they liked was content, the positive experience of using the patient DA, and the format and design. Top three suggestions was to provide information about treatment options and medications, improvements to design, and provide more information. So the conclusion from what we've done so far in this journey in the last 13 years is this. I think that by developing and disseminating a patient-centered, culturally appropriate, self-administered decision tool for lupus, which is free of cost, I think we provided an option to patients. I think that we also have demonstrated that this decision tool can be provided to the patient at regular outpatient visits or via QR code. I think our challenge remains what remains in healthcare settings in any implementation project, which is, even though we've implemented this at 15 sites, once the project stops, I have no idea how many sites are still using it. I'd be shocked if more than 5 are still using it. I think all the tent cars, the paper tent cars are gone. I think the physicians may have forgotten. We have no way of auditing these sites and going to them. We don't have funding to do that. We're hoping and planning to do a follow-up with the site PIs who are all with us now that 1 year has passed. We'll have to organize that. I think we've shown that this is effective. We've shown that patients love it. We know that patients can easily access it if the healthcare professionals make it a point, highlighting its usability and their confidence in it. But it still remains to be seen what will happen to the future. So I'll stop there and take questions. I know I want to leave a lot of time for questions and interaction. So